So, hello everyone. Today it's a really pleasure and a great honor as well. Dr. R Tabbah is again with us, and I hope our audience will remember that she's a cardiologist who has studied in Holy Spirit University of Catholic at Lebanon and currently working at Notre Dame de Secours University Hospital, Chins. And she is a budding talent and also which is very interested in the EP and imaging. And earlier as well, we did few sessions with Dr. Randa, and she's always very enthusiastic about sharing her knowledge and her experience as well about the interesting topics. So today we are going to learn with her about the resuscitation in the COVID-19 patients. It is an important topic and slightly also different from the common patients as well. So let's try to learn from Dr. Randa. Over to you. Thank you.
Thank you so much for this introduction. So let's discuss resuscitation in COVID-19 patients. So in resuscitation in COVID-19 patients, the most important topic is to reduce the exposure, of course.
Mm-hmm.
So first, we're gonna discuss the adult resuscitation. So if an adult's heart stops and you're worried that they may have COVID-19, you can still help them by performing hand-only CPR. First, you have to call for help, get an automated external defibrillator, cover your own mouth and nose with a face mask or cloth, and cover the person's mouth and nose with a face mask or cloth. And of course, perform hand-only CPR. Push hard and fast on the center of the chest at a rate of nearly 100 to 120 compression per minute. Then use an external defibrillator if it is available. So for the basic life support algorithm, first you have to verify the scene safety. The most important is to use PPE to limit the personnel. If the victim is unresponsive, so first look for breathing, look if the patient is only gasping, and check for the pulse. If the patient has normal pulse and normal breathing, so you can only monitor until emergency responses arrive. But if the patient had no normal breathing, but a good pulse, then you can use a bag mask device with a filter device reduce the viral load. And one breath every 5 to 6 seconds, or about 10 to 12 breaths per minute. And of course, check the pulse every 2 minutes. And if no pulse, you have to start with CPR. CPR, you have to begin cycles of 30 compressions and 2 breaths using bag mask device with filter and tight seal, of course, or continuous compressions with passive oxygenation using face mask, and use the external defibrillator when it is available. So when it is available, you have to check the rhythm. If it's a shockable rhythm, then give one shock, then resume CPR immediately for about 2 minutes, and of course recheck the rhythm and the pulse. And if it is non-shockable rhythm, so resume CPR and check every 2 minutes to see the pulse and the rhythm, of course. For the advanced cardiac life support algorithm, we have to also start with PPE, of course, to limit the exposure and limit the personnel, of course. Consider resuscitation appropriateness, start CPR, give oxygen, limit aerolization, and attach monitor and defibrillator and prepare the patient for intubation. If it is a shockable rhythm, then it is a VFib or VTAC, patient in VFib or VTAC, and then you have to shock the patient. And if it is asystole or pulseless electrical activity, so no need to shock, you need to resume your CPR. Of course, you have to prioritize intubation, pause chest compression for intubation. If intubation is delayed, consider a supraglottic airway or bag mask device with filter, of course, and tight seal, and connect to ventilator with filter if it's possible also. So if the patient has a shockable rhythm, as we said before, continue CPR for 2 minutes. You have to have an access, of course, and see for the rhythm. If it is a shockable rhythm, then shock and continue CPR, give epinephrine every 3 to 5 minutes, consider mechanical compression device, of course, to reduce exposure, and also continue to check the rhythm for shockable rhythm. If it's shockable rhythm, CPR for 2 minutes, amiodarone or lidocaine to treat. And of course, if you have known reversible causes, you have to treat them also. If the patient is in asystole or in pulseless electrical activity, so CPR, epinephrine every 3 to 5 minutes, consider mechanical ventilation and mechanical compression. Then see the rhythm. If it's not a shockable rhythm, then continue CPR and treat to treat the reversible causes, and continue for cycles until you see the return of spontaneous circulation. Okay, for the pediatric population, first, of course, if a child or an infant heart stops and you're worried that they may have COVID-19, you can still help. You have to make sure that the scene is safe, check to see if the child or infant is awake and breathing normally, and provide CPR with compression. If it's a child, push in the middle of the chest with a depth of 2 inches, and provide 30 compressions and then 2 breaths if you want to, and repeat the cycles. If it's an infant, so you can use your 2 fingers. You have to use your 2 fingers with a 1.5 inch depth, and provide 30 compressions and then 2 breaths to repeat cycle. Okay. So for the pediatric population, the basic life support, of course, we don't have to forget the PPE to limit the personnel, to watch if the patient is unresponsive, to see his breathing and pulse. If no breathing, if it has a normal breathing and normal pulse, so you have to monitor the patient. If no normal breathing, then use the bag mask, as we said before, with a filter, of course. And if compressions, and you have to add compression if the pulse remains less than 60 beats per minute with signs of poor perfusion. And of course, check every 2 minutes the pulse, and if no pulse, we have to begin CPR, as we said before. So if no breathing and no pulse, then CPR, begin cycles of 30 compressions and 2 breaths, using bag mask device with a filter, as we said before. Check for the defibrillator. If we have the defibrillator, then we have to analyze the rhythm. If it is a shockable rhythm, then we give 1 shock, then resume CPR immediately for about 2 minutes, and check for the rhythm and pulse. If no shockable rhythm, so resume CPR immediately for about 2 minutes, and repeat checking also the pulse and the rhythm. For the advanced algorithm, okay, so as we said, the most important thing to do in these cases is the PPE to limit the personnel. Then start your CPR, ventilate with oxygen using bag mask device with filter with tight seal. If unavailable, use non-breathing face mask. Attach, of course, the monitor and the defibrillator, and prepare for intubation. In case of a shockable rhythm, VFib or VTAC, you need to shock the patient. In asystole or pulseless electrical activity, you need to resume CPR. You have to prioritize intubation, as we said before. pause chest compression for intubation. If intubation is delayed, then consider supraglottic airway or bag mask device with filter and tight seal, and connect to ventilator with filter when possible. Okay, so patient here is with a shock rhythm, then we continue CPR for 2 minutes as for the adults. C for the rhythm. If it's shockable, then give also epinephrine every 3 to 5 minutes. If it's also shockable, give amiodarone or lidocaine and treat reversible causes. If it's a pulseless electrical activity or asystole, start first with epinephrine every 3 to 5 minutes. Then if it's a shockable rhythm, if it's not a shockable rhythm, continue CPR every 2 minutes and check for the rhythm and pulse. Okay? So what about CPR quality? CPR quality for adults and pediatrics you need to push hard, of course, at least 2 inches or 5 centimeters for the adults, and more than a third of the anteroposterior diameter of the chest for the pediatric population. And also you need to be fast, 100 to 120 beat per minute, and allow complete chest recall. Of course, it is important. Minimize interruption in compression in both adults and pediatrics. Avoid excessive ventilation. Change compressor every 2 minutes or sooner if every 2 minutes, it's important. And of course, you have to check the waveform capnography and the intra-arterial pressure. So for the shock energy, in the adult population, if we have a biphasic defibrillator, then give 120 to 200 joules for the first shock. If it is a monophasic, give 360. And for the second or subsequent doses, you can be equivalent or you can higher the dose as you consider. For the pediatric population, the first shock would be 2 joules per kilo. The second shock will be 4 joules per kilo, and subsequent shocks will be more than 4 joules per kilo, maximum 10 joules per kilo or those adults, okay? For the advanced airway, so you need to minimize closed circuit disconnection. Use intubator with the highest likelihood for first pass success, of course, to reduce, of course, also exposure. And consider video laryngoscopy if it is less difficult, okay? Then endotracheal intubation or supraglottic advanced airway for both of them, and prefer the cuffed endotracheal tube for the pediatric population. For the drug therapy, also epinephrine, as we said before, 1 milligram every 3 to 5 minutes for adults. Amiodarone, first dose 300 milligram bolus, then the second dose is 150 milligrams. For lidocaine, first dose it's 1.5 milligram per kilo. Then the second dose will be 0.5 to 0.75 milligram per kilo. For the pediatric population, also we have the dosage. Okay, so for the spontaneous return of circulation, we will have the pulse, the blood pressure, and the spontaneous arterial pressure wave and intra-arterial monitoring. So what are the reversible causes? We have the 5H and the 5T, hypovolemia, hypoxia, hydrogen ions, which is acidosis, hypo and hyperkalemia, hypothermia, tension pneumothorax, tamponade, cardiac tamponade, of course, toxins, pulmonary thrombosis, or coronary thrombosis. So as a summary of adjustment to CPR algorithm in suspected patient or confirmed patient with COVID-19, first, you need to reduce the exposure, of course, use PPE, limit the personnel, consider using mechanical CPR, as we see here, device for adults or and adolescents who meet the height and weight criteria, and communicate COVID-19 status to any new providers, okay? So prioritize oxygenation and ventilation strategies to lower the aerolization risk. Okay, so use filter if available for all ventilation. Intubate early with cuffed tube if possible and connect to mechanical ventilation. Engage the intubator with highest chance of first pass success, of course. Post chest compression to intubate. Use the video laryngoscopy if available. And before intubation, use a bag mask device with a filter, of course. For adults, consider passive oxygenation with non-breathing face mask as alternative to bag mask device for short duration. If intubation is delayed, so consider supraglottic airway. Minimize closed circuits disconnection. And here we can see intubation with decreasing the risk of exposure. You can see here the CO2 adapter, the viral filter, which is the most important thing to do. Here also we have the viral filter. And of course, consider resuscitation appropriateness, address goals of care, adopt policies to guide the determination, taking into account patient risk, gratitude for all doctors, nurses, and healthcare professionals who are risking their life to assist patients in needs and cure COVID-19. Thank you.
Thank you so much again for sharing the insights, and it is very important the way in which you explained to us about the importance of the CPR. So you beautifully summarized about the CPR protocols, which is available for not only the adults, but also for the pediatric population, and also the special way, for example, how it should be done, why it should be done, and the different compression ratio as well, and even how much it should be substituted with the respiratory breaths as well, which it should be given. And you emphasize it very well, what is called as effective compressions as well, because just doing the compressions alone is not enough. We should be able to know that are they good enough? The quality, is it good enough as well? And the shock as well, the kind of monophasic shock versus the biphasic shock as well. And one of the other important things which you shared very well with us was about the amount of juice which should be used for the pediatric populations, so starting from like 2 joules per kg, then going up to 4 joules per kg as well. And again, the concept of advanced airway and the return of spontaneous circulation is also very important. Whenever we are dealing with the cardiopulmonary resuscitation, we do get lost a lot of times in the stress of the situation which is going around. So we should not forget about those reversible causes as well, which you summarized it very well. And even about our COVID patients as well, the simple modifications, if we try to do in the protocols, whichever we are using as well, it can be helpful not only for the patient, but also for the healthcare professionals as well. As you rightly said it, healthcare professionals are being at the front line, and they do have a higher risk of getting themselves infected as well. So the use of viral filters, which you said it, and especially about those modifications, about the simple things like, for example, the usage of a box as well, which you showed it to us. It seems very simple, but a big difference. It makes a big difference. So we can not only keep our patient safer and better, but also our healthcare professionals as well in a much safer way as well. So that was really, really important as well. So thank you so much for summarizing everything and all in such a nice ways as well. And one of the other key things which I had learned as well, just now it is coming into my mind, is there are some newer techniques which is being advocated, like, so to do CPR for those COVID patients, we can turn them around. So we can just, rather than compressing on the chest, we can turn them completely around. So they'll be literally on their chest lying down, okay? And we have to compress in the back. So in the correspondingly same area as well. And with the same interlocking of our hands, we can continue to do the compression. So some of the advantages which is being suggested for that is uh, the chances of aerosol generation, which is going to be there from the mouth of the patient, is going to be in completely opposite direction. And again, the chances of any further infection to the healthcare professionals will be slightly lesser. And also it happens is COVID patients may feel better when they are upside down in the lying down position, because
The
it tends to,
pronation.
right, absolutely right. Because it tends to cause better relaxation of the lungs and better deflation of the lungs as well. They will be in more expanded position, so there will be higher chances of oxygenation as well. So very well added up, Dr. Randath. Thank you so much. And as always, really a pleasure to learn from you. And thank you for sharing all these kind words. Thank you so much.
Thank you.